And it's a pleasure to introduce Jen DeVoe, and she is the PI of another clinical data research network, one based on safety net clinics across the country. And I think she'll bring a very fresh perspective and synergies to what we're doing in P-Scanner, UC Rex, and all of these other projects. So please welcome Jen DeVoe, who is Associate Professor at the Department of Family Medicine in Oregon Health Sciences University. She's an internist and Chief Research Officer of OCHIN.
Thank you so much, and thank you to Lucilla for this wonderful invitation, and congratulations on all the work you've done. I learned a tremendous amount today, and will look forward to collaborating with you all as part of PCORnet and beyond. So I have a few goals, and I've told our timekeeper already to, wave papers and throw tomatoes at me or whatever if I keep going, because I have a lot of very exciting ideas and things to share, so sometimes get long-winded. But hopefully what I aim to do today is to describe our team's progress in building what we're calling a community laboratory of safety net clinics across the country, to present examples of some of the work that we're doing in our thriving community laboratory, which started with the OCHIN Practice-Based Research Network and is now expanded as a clinical data research network in the same way that some of your networks are as well, to be a national network, which we're calling ADVANCE. So why am I here today? So I'm a family physician. I still see patients in a community clinic, and was introduced to the ecology of medical care, which was initially created in the 1960s by Carr White and then reproduced by Larry Green in 2001. And it really looks at a month and 1,000 people in the United States and what happens with their health care-seeking behavior. So if you look at, and I'll see if I can do multiple technologies at once here. Maybe, maybe not. Obviously not, so I'll just wave my hands over there. So the top box is that there's 1,000 people, and among those 1,000 people, about 800 report some type of a symptom. About 300, just over 300, consider seeking care. 217 visit a physician's office, and more than half of those in a primary care physician's office. So again, where I spend a lot of my time. And you kind of follow those boxes down. A very small percentage end up in a hospital outpatient clinic. Smaller percentage are hospitalized, only 8, and less than 1 are hospitalized in an academic health center. So we got very passionate about the fact that much of our data, training, and research happens in that very small box. And we're missing everything else, potentially. We're starting, again, to build those bridges, but we need to do a lot more work in getting research and information and the work we're doing out into the community. So we partnered with an organization called OCHIN, and it started as the Oregon Community Health Information Network in 2001. It's now called OCHIN because it's in over 20 states, obviously far beyond Oregon. And in 2001, there was a group of community folks who said, we see that electronic health records are the future, we see large hospital systems implementing them, and we don't want primary care and the safety net to get left behind. So they formed OCHIN. At the time, everyone thought we were crazy when we said we're going to put an EPIC record, the Cadillac record of electronic health records, into the safety net. But we succeeded, and we are now, we have a linked EPIC electronic health record, one master patient index across 300 primary care sites in the country. Over 1 million distinct patients, 13 million visits. Soon thereafter, we said, gosh, we really have an amazing data resource here. We registered as a practice-based research network and established our community-based PBRN. We were very lucky in riding the wave of the stimulus funding and saying, wow, we really need to build this infrastructure, and so established our formal department in 2010 and are now receiving funding from PCORI as part of the PCORnet, one of the CDRNs. We also have funding and partner with investigators funded by NIH, ARC, HRSA, et cetera. And we've partnered with a number of researchers from across the country because our goal is not to build another home where we have a lot of investigators, because academic health centers are where investigators live and thrive. It's more to partner and provide the kinds of laboratories that we in academia are really looking for and need to be partnering with in order to be representative of clinicians and patients in the community. So OCHIN is very unique in a number of ways. It's one of the few organizations right now that's aggregating healthcare data and statistics from low-income and uninsured populations. And I'm from primary care. I also have a background in health services research and health policy research, very interested and passionate about reducing healthcare disparities. So I was drawn to OCHIN because a number of my health services research colleagues were using insurance claims data to represent communities and populations. And I continually ask the question, what about the uninsured? There are no claims for uninsured. And I still have people asking me that question. What do you mean? Insurance generates the claim. If you don't have insurance, you don't. I tell you, I still get asked that question multiple times. What do you mean there's no uninsured folks in claims data? So looking at electronic health record data as a very, very rich source of what's happening on the ground in healthcare settings, who's utilizing care in what ways. We also know that electronic health record data is much deeper in terms of the snapshot you're getting. Claims based on billing, so you're losing a lot of the depth and breadth and richness that we have in our clinical data. So we're beginning to recognize that we have this very innovative organization. We're not only storing this huge amount of data, but we're also working with a number of very talented people to build IT tools that are helping primary care clinicians and safety net clinics with their clinical decision support needs, some of the very unique needs that they have related to that patient population. So when we started the Practice-Based Research Network, we were across these states here, and as I mentioned, we have representatives from racial and ethnic minority groups. We have over 50% of our population is living below the federal poverty level. We have over a third of our patients that are self-pay, i.e. uninsured, and over 50% federally insured, primarily through the Medicaid program and some through Medicare as well. So with that as our foundation, the OCHIN network, we said we would really like to be at the table in the PCORnet and become a CDRN. And we had a number of academic folks approach us and say, would you partner with us? And a number of our community stakeholders said, our experience has been that what happens at the academic health centers doesn't trickle down into the community. People want our data and we don't see them again. They said, if we're going to do this, we have to lead it and we want a seat at the table. So we said, okay, we'll see what we can do. So we're very unique in that, and I guess a fresh perspective, or perhaps a different perspective in some ways, to be leading the CDRN based out of OCHIN, a community organization. We have now outpatient clinical data from 99 federally qualified health centers, and we're really working with and alongside community clinicians and patients to build this community laboratory. And perhaps we're taking the bottom-up approach as opposed to the top-down approach, and I'll show you what I mean by that in a few slides later. But we have a number of strategic partnerships now with our communities as well as health plans and hospitals to try to bring in this longitudinal and complete data. The partner, so OCHIN is our leader, and OCHIN's based in Portland, but as I mentioned, it's a nonprofit collaborative of health systems from now across 20 states. We're partnering with Health Choice Network, which is another health center controlled network based out of Miami, Florida. We're working with some of our hospital systems that share a number of the same patients, one being Legacy Health based in Portland. We're also working with the Fenway Health Federally Qualified Health Center out of Boston, Massachusetts. We partner with the Kaiser Permanente Northwest Center for Health Research, where we have a number of investigators working on collaborative studies. Also, Oregon Health and Science University, where I'm based, and a number of colleagues that lead many of our studies as well. The American Academy of Family Physicians, Robert Graham Center, and Virginia Commonwealth University. So one of the really important things, again, with our stakeholders is we have academic organizations and community organizations, but unlike most where the academics the lead, in ours the community is the lead, and we have the academic partners. And of course, none of us could do this without our partners, but it really kind of tipped the table so that we're really bottom up, and our stakeholders are very, very engaged. So here's our network. You'll see the green states and the blue states, but really marching across 23 states and growing. We have a large population of women and children. And sorry, the graphics are a little hard to see, but essentially the circle at the bottom, the large green chunk, which is really the biggest chunk across Advance, over 40% of our patients were uninsured. Ideally now that number is dropping as we see insurance expansions across the country. So we were really excited. Oh my gosh, we're getting together all this data. We're getting out of that little tiny box. And then we were humbled again, and this is a good reminder, the World Health Organization looking at all of the social determinants of health, what impacts on equality or on equity in health and well-being. We're in this tiny little box down here, health systems. That's where all of our data is coming from. So we said, oh, geez, okay, it's going to be enough of a challenge to learn all that you all know about informatics and bringing all this data and this clinical data together and normalizing it, standardizing it, harmonizing, et cetera, and then knowing that our data is really coming from that small little box. So as I mentioned, our data strategy has become much more holistic and hopefully, well, more complex, but hopefully more comprehensive. And it really is starting at the bottom. So where are these patients getting their primary care? Starting there. Ocean has over 1 million patients now that have been seen within the last 3 years. Health Choice Network has about 600 to 800,000, and Fenway, smaller, but specific to the HIV population. We're going to start there and say, this is our patient population. Here's what we hope to be the denominator. Now you might ask, okay, great. Now you have their primary care data, their outpatient data, but you don't know about what's happening to them when they enter the hospital. Oops, sorry. So we then said, well, we're going to partner with hospitals to bring in hospital data, as well as some of our primary payers, the state Medicaid organizations and others, to bring in both the claims data and the clinical data from the inpatient setting. But really what we also need is we need this community level data, which is the gray circling that, so that we really understand the context within which our patients live. And there's a lot of really excellent work being done to look at neighborhoods and at least at the neighborhood level understand factors that impact on our patient's health. So starting there, we ideally have an address for the patient. We can really understand what's the context of at least the neighborhood they live in. Of course, then we can start asking the patient to get that patient-reported outcome data and that very rich data as well. But as I said, we thought, oh, great, we've got this great strategy for clinical data. We've got all these hospitals on board. We've got payers on board. And then we said, wait a minute here. We actually need this community data as well. So just to give you a few examples of the work that we've already been doing, and as I mentioned, I'm a health services researcher, health policy researcher, so my focus has been a lot on the comparative effectiveness of different policies and different healthcare delivery system changes that we're making in how we deliver care and how patients receive care. So one of the first questions that I asked when we got involved in working with OCHIN is how can we use our electronic health record data to understand our population's access to health insurance? And again, we just said, let's look at the information that we have for our child population. So at the time we had over 184,000 children in the OCHIN network for 2 years. And very basically just looked at what type of insurance did they have when they presented for care. So on the left-hand side, you'll see their initial insurance status at their first visit. Over 21%, or 1 in 5 of these children, were uninsured at their FQHC visit. This is over 10 years after the Children's Health Insurance Program apparently gave almost every child health insurance. And then, okay, well, maybe they had just lost it on that one day, but as soon as they presented to the clinic, we got them re-enrolled and they were insured. Not the case. So at every subsequent visit, those that were uninsured, almost half of them re-presented on subsequent visits uninsured as well. So it was really just a great snapshot to say, let's look at this data, let's talk to our clinical leadership, and say, here's the kinds of information that we can begin to understand based on our data, and then what do we want to do about it? More recently, and I apologize again for the small print, but we have a number of states in our system who are expanding Medicaid and a number who are not. The comparative effectiveness of really what's happening in these two different populations. So we've done a very first pass at looking at federally qualified health centers in states that expanded Medicaid versus those that did not. And again, it's very busy, but if you look over in the expansion states, you'll see the green line perhaps is the most dramatic in terms of the percent of uninsured visits drop precipitously after January. Similarly, the purple line, we have a couple states down at the bottom that actually expanded their Medicaid program a year or two earlier, so their numbers would have been earlier than what we catch here. Non-expansion states, there wasn't a whole lot of difference in terms of the percentage of uninsured patients coming into the clinics. This is another slide really kind of showing the same thing, but looking at the payer at the visit. And the green line, you'll see that the Medicaid, those visits paid by Medicaid, jumped up significantly after January, as you would expect. About 7.2 million Americans have gained Medicaid since January, and so we're seeing many of those folks now coming in with insurance, and those folks were probably coming in uninsured or maybe not coming in at all. So we're just in the very early stages of understanding what our data is telling us about this very interesting natural policy experiment that we need to study the comparative effectiveness of what's happening. And then we kind of got into additional questions about how do we know that health insurance is affecting our population. You'll hear a lot of people say, well, they have access to a community health center, they have access to an emergency department, so maybe health insurance isn't going to change the way they utilize care or the way they receive care or potentially their health outcomes. So Oregon had a very interesting randomized experiment in 2008 that we're in the process of studying through the data in our laboratory, where they randomized the population that potentially could be eligible for Medicaid. There were about 100,000 folks that were in the original Oregon Health Plan that we couldn't cover for a period of time. And then when it turned out we had about enough money to cover about 10,000 folks were randomly drawn to have the opportunity to apply for Medicaid. So we, of course, still live in a country, which is incredibly sad, where we have these types of experiments going on. So 10,000 out of 100,000 folks were randomly able to obtain Medicaid. We were able to probabilistically match the original reservation list of those 100,000 to the OCHIN PBRN patient list and found about 35,000 of those folks in our patient population, and then just use the electronic health record data to look at some different groups here. So the green line at the bottom, these are patients that were uninsured for this 2-year period, essentially the continuously uninsured. And then the blue line in the middle here were those that had insurance for a full 2 years. And then the red line are the people that started uninsured, gained insurance about halfway through, and you'll see their utilization jump significantly. There's similar studies looking at the Medicare population. When someone goes from 64 to 65, there's pent-up demand in the needs that they have, and they utilize more care. So this is, again, a first pass, just looking at what would our workforce needs be if everyone gained insurance overnight, and how would those folks utilize care. This was just looking a year post-2008. We now have studies going out 3 years. And after you see this pent-up demand, the numbers, the lines stay about where they are. But those folks that gained health insurance don't ever go back down to the green line. So they're really utilizing and needing, potentially you could argue that, but needing health care at a much higher rate. Then we just looked again at different subpopulations within that. This was a diabetic cohort that we were looking at, where we hypothesized that having continuous insurance would likely result in them having a cholesterol screening over this 3-year time period. And regardless of the fact that they could get in the door and they could get a visit, they needed the insurance to get testing done and to pay for some of the specialty services that their diabetes required. So the continuously insured safety net patients were more likely to receive cholesterol screening. And it was interesting because we saw this partially insured group actually doing worse than the continuously uninsured group. So we started wondering, is more insurance better than less insurance, or some gradation there? And really, when we did this, looking at the dose response, among the partially insured, more coverage was no better than less coverage. So it was really an all or none. Another study that we were able to do with this cohort was really just look at the variability and the quality of diabetes care. A number of people now are using clinical data to measure quality, and they're measuring apples and apples, and they're saying, gosh, this clinic's doing a whole lot worse than that clinic, without really adjusting for factors that may be unique and different in those two patient populations. So even within our network of federally qualified health centers, who you would argue have a fairly homogeneous patient population, they're all poor, many are minority, they have a number of social determinants of health that are contributing to their ill health. We saw there was a significant amount of variability, and it was correlated directly with characteristics of the clinic's patient panel. And in this case, we looked at the percent of the panel with continuous health insurance. This was another study looking at our hypothesis that, well, maybe those folks that were receiving poorer care or not receiving all their care were just not coming in for visits. And this is a busy slide, I apologize, but we initially showed that, yes, lack of insurance was associated with fewer primary care visits, resulting in lower odds of a clinic visit when a service was due. However, when we were able to look at the patients that did come in for a visit, lack of insurance was still associated with lower odds of receiving the service due at the visit. And that has a great explanation. If someone's uninsured, they're going to come in for an urgent need, they're going to be seen acutely, and catching them up on preventive health needs and chronic disease care management is probably going to be secondary there. It doesn't become a priority. So we really looked at we have a population that's uninsured. We have these opportunities for them to gain health insurance. So how can we use our clinical data and how can we use our electronic health record to build tools to help these patients gain insurance? So we're in the process now of a study that was funded on one of the early PCORI projects related to health systems in how can we take what we already know in the electronic health record data and build tools both at a clinic visit, so in reach, as well as outside the clinic visit and doing outreach to begin to identify children for this study, but we have another study now looking at adults, and link them up with insurance products or programs that they may now be eligible for. And so really putting more of that into the clinic's hands and then building the HIT tools that would help facilitate that in-reach and outreach. We also were able to take electronic health record data and put it into geospatial maps and help some clinics identify areas within their community where there are higher or lower rates of uninsured kids coming into their clinic, so they could work with community organizations to target those specific areas. And again, this is a map of Oregon, and then it's sort of zeroing in on this particular area where there was high rates of uninsured and really allowing the electronic health record data, the neighborhood level data to really help inform communities. So we're just doing a lot of really cool stuff, and it's been a phenomenal experience and wonderful working with Ocean and the community clinics, as well as investigators and folks that are really engaged and excited about doing this work. So a few other examples. So I sort of put the work we're doing in a few different buckets, and it's, I've heard the metaphor, we're building the plane while we're flying it. I also feel like we're building it, we're repairing it, we're flying it, we're adding on the wings, we're adding on the seats, doing all of this simultaneously. And we can't wait until our clinical data is perfect, I guess is what I'm saying. We have to keep using it for studies and then iterating on the improvements. So one of the things that we initially did right out of the box was we said, we obviously need to develop better data sources. So first we had to convince people that clinical data was more robust and certainly more appropriate for using in our population than claims data. And this is, again, a busy slide, I apologize, but essentially we took a population of Medicaid patients, this cohort, from the Ocean clinics. We matched their data with what we knew about their receipt of care from the Medicaid claims. And we then just looked at 4 process outcomes. Did they get LDL screening? Did they get a flu shot? Did they get nephropathy screening? Did they get their hemoglobin A1C checked? And what information was in each of those 2 data sources? And then when we put them together, and you may have heard the analogy, they're like Swiss cheese. Clinical data has holes, claims data has holes. If you layer them together, hopefully they cover each other's holes. And we found that to a certain extent. But if you're going to look at one data source versus the other, certainly in our population with uninsured and discontinuously insured folks, we found, and really the meat here is in this red area, this was only found in the Ocean data. So if you looked at the clinical care being provided to this population with only Medicaid data, you would miss the vast majority of services that were being provided. We did some similar work with children's quality indicators, looking at BMI, immunizations, well child visits, chlamydia screening. And again, it was variable in terms of whether the data was in the claims and the EHR, or only in the EHR, or only in the claims. This one was looking at electronic health record data and claims and receipt of preventive services and how much agreement you saw. And so if you look down here, influenza, there was a lot of agreement between the 2, cholesterol screening, all the way down to very little agreement with colonoscopy. And primarily it was really what data is available and what source. And so something like colonoscopy and mammography, where the primary care physician is going to refer out, you may see the order for that, but you won't necessarily see the information yet in an accessible form, because our specialists love to fax us information that gets scanned in, and as we know, it's really not accessible. So this is, again, we have a lot of work to do in terms of let's use the data and ideally bring it together with other sources of data, but at the same time, let's figure out how to improve our workflows and improve the percentage of discrete data that we're able to access. Once we sort of convinced people, yes, this is a data source that we want to use and we want to continue to develop, then we started saying, let's study system changes to improve adherence to evidence. Let's do some comparative effectiveness work. And our clinics are really, really excited about doing cluster randomized controlled trials. We have so many clinics now that we do have the ability to say, let's recruit. In this case, we recruited 12 clinics and we randomized 6 to get clinical decision support early in the study, and then 6 to get it late. And this really just shows diabetics that were prescribed statins and ACE inhibitors and angiotensin receptor blockers. And you'll see that the late clinics in the red kind of continued with usual source of care, whereas the intervention clinics improved significantly when they implemented the tools. And then once we've done the efficacy studies, we have to think about the effectiveness, the dissemination, and implementation. So we're also doing some really exciting studies related to that. I have only 5 minutes, so I'm going to run through a couple more here. I think the other piece of information that I want to leave you with is that we have to have our community laboratories go far beyond research. We need to be partnering with communities. Communities want access to data. They're wanting to become learning systems for health. This was the community as a learning system. And again, seeing us down here, the academic and community data partners, really feeding our data into these larger systems to really help our communities improve health. At Ocean, we're now calling ourselves a patient-centered medical village, where we're really wanting to provide the IT and the data and the systems to bring together multiple primary care medical homes and really help them improve the work they're doing by not having each one individually recreate the wheel. And this is, again, another big picture that I've been showing at our academic health center quite a lot, is we really are part of, again, we're doing really cool stuff, but we need to see ourselves part of this larger ecosystem. We are seeing ourselves as part of the infrastructure to support population health. So we're the real world laboratory. We're out there in the community health centers. We have these core resources of data, measurement, analytics, and engagement. But if we really bring this all together in partnership with patients and families and communities and supporting it with our multidisciplinary centers across campuses and across communities, I think we're going to get to where we hope to go in 2020. Where we've developed and enhanced scientific methods for studying natural experiments, comparing the effectiveness of real-world interventions in real time, and measuring patient-centered outcomes. For us, it's really accelerating primary care transformation, innovation, and discovery, and developing partnerships for patient engagement and care plans and research studies. Partnering with communities to develop big data methods and useful data sets to support communities as learning systems, and to inform and measure population health improvements. To really strengthen the infrastructure of our community laboratories and classrooms that innovate, evaluate continuously, and train our future generations. So thank you very much. Appreciate the invitation.
As promised, a very intriguing presentation, very nice work. Mike Hogarth has a question in the back.
Great presentation, and I just wanted to commend Ocean and you for some great work. I got to work with Ocean a few years back on the COPD project, and I was very impressed with the organization. One question, are you able to analyze patients who are uninsured and undocumented?
Yes.
And
Any patient that is using our clinical system in any way, we would have their data.
Because I think that's a very underrepresented population, I think, now, and it'd be really important to keep focus on that.
We need your help to identify those folks. I have someone doing a K award who's really focused on that, but it's very difficult, as you might imagine, to determine in our clinical systems who's undocumented and who's not. We have a lot of birth dates of 01, 01, 01, and a lot of social security numbers of 999999999. Some of them are citizens, some of them are not. So we don't have any great algorithms unless you all know of something, some secret literature out there that my K awardee hasn't uncovered, but absolutely.
Danielle.
So fantastic work. I second the motion. I was very intrigued by your slide that showed the different sort of overlap and gaps between claims and EHR data in this population especially. And because you have some coverage in places that do have HIEs that are sort of working, have you done the same kind of analysis in that sort of crossover between what you would like to see in HIEs?
Great idea. We have not, but great idea. Yeah, I will say that I make it sound easy, but it was several years of negotiating with our Medicaid office to get access to Medicaid data that had patient identifiers so that we could do the deterministic match. You can get data from ResDac to do a probabilistic match, but much more difficult. We also have an all-payer, all-claims data system in our state that was touted to solve all problems, but it's not identifiable in any way. And when researchers want to use it, we have to sign super secret documents saying we will not probabilistically match it to any other data sources at this point. So.
It's exactly the counterpart of our de-identifying things. There are methods to re-identify, and we are working just on both ends of the spectrum. So I will now thanks Jennifer once again